Hi, everyone. We're going to start the meeting now. We're a bit late. So welcome to Congenital Heart Hour. My name is Salim Javanji. As you know, this meeting is about congenital heart disease and its impact and treatment. The topics this year will be broader and also cover some EP topics which have been requested on our feedback forms from various different countries. The topics we will be discussing will be around congenital heart disease, its clinical management, service delivery, and challenges. We'll also include new and existing treatments, which will include both surgical and cardiac catheter. I'm excited to say that the number of speakers from international centers will increase over the year. And I'm also happy to report that our community is growing with an audience of about 24 countries at the moment, with a weekly audience of more than 120 attendees. Before I introduce today's talk, I just want to let you know that for the next couple of weeks, we're going to have a bit of a break for Easter. So we'll rejoin after about 2 weeks of a break. I would like to thank our sponsors who made these talks a success. Today, our talk has been sponsored by Ocotec. Thank you for supporting us, and we're very grateful for all that you've done so far. During the talk, if you have any questions, please put it on the Q&A, and then we'll address it at the end. Today, it's my real pleasure to introduce Mr. Dhannapuneni. He's one of the senior surgeons at All Day Hospital. I've known him for longer than I've met him physically. When I work in healing little hearts, he's got a very good reputation across the country and internationally. And he's going to give us a talk on neonatal cardiac surgery. So I'm really honored and pleased to have him on board. Thank you.
Thank you very much, Salim, and thank you all for this invitation. So this presentation is not a hardcore clinical scientific presentation. So it gives a bit of perspective, history, and etc., and the challenges which we face. Interest in heart surgery started from early 20th century, 1920s onwards. But we need to remember that the anesthesia became available sometime during later half of 1800s with chloroform anesthesia. So the interest in cardiac surgery initially started with cardiac trauma because stab wounds. I think guns were not that popular in those days. Cardiac trauma is something surgeons faced in those days. They needed to deal with that. And afterwards, it's a pulmonary embolectomy. Then the confidence grew that they can operate on the heart or related structures. In 1940s, they started with closed heart operations. And then from 1950s, we started operating with the techniques of deep hypothermic circulatory arrestia. And then another group started operating with controlled cross circulation. I will cover those things briefly. And then around the same time, the first operation was performed using heart-lung bypass mission. So during this period, from 30s to 50s, there was a lot of research went on in developing heart-lung bypass missions. Cardiac trauma, so first reported in 1920s by Ren from Frankfurt. He's operated on 134 cases with 60% mortality. That's not bad. These are all stab wounds to the heart. If they survive, they're lucky in those days. But then Dwight Harkin was a US Army surgeon. So he treated 134 bullet injuries to the mediastinum, after which 13 were retrieved from the cardiac chambers without any mortality. And that, in those days, a very successful cardiac surgery. Then around the same time, the interest grew in pulmonary embolectomy, and actually an operation was devised and called on his name, Trendelenburg operation, where they've occluded the pulmonary arteries or inflows, opened the pulmonary artery, put a catheter in and sucked out the embolus, and then later put the sucker in and then remove the emboli. So the first survivor was operated by Trendelenburg's trainee, Krishner. And that around the same time, 1930s and etc., John Gibbon looked at all pulmonary embolisms, and he estimated that only 9 survived to leave the hospital. This and one particular case had profound effect on him. He needed to look after a young patient with pulmonary embolism overnight, taking observations every 15 to 30 minutes. And that time he thought that why can't we have something, a machine who can function as an oxygenator and a pump, then we can operate on this patient safely. I think that was his inspiration. He worked for 20 years. He had to have a break during the World War time to go and serve the US Army. But then he came back and he started working on heart-lung missions. So the first successful congenital heart surgery, we say with success, but it's reported in 1937. A PDA was closed in a 22-year-old, but the patient died in 4 days later. At autopsy, they found that the vegetations all the way from PDA to the pulmonary valve. But the patient didn't survive. But the first successful survivor in 1938 was operated by Robert Gross. Sorry, it's not Goss. He was chief resident in Boston Children's Hospital. He wasn't a surgeon at that time. And he ligated the PDA in a 7-year-old girl at that time. And the girl was alive for many years afterwards. Around the same time in Sweden, Clarence Crawford, he operated and reported successful coarctation repairs. Robert Gross was working around the same time, not knowing, and he reported his first success in 1945 with coarctation as well as vascular ring. Same Gross operated in 1948 with an AP window. So what he did is he put in a tape around the AP window, and then they started losing the blood pressure with bleeding. But he just went ahead and then tightened the tape. Luckily, the patient survived. So he has written that I was lucky that this patient survived, but there should be methods available to support the heart and lung to do these operations. So the significant movement in congenital cardiac surgery happened in 1944, 29th November 1944. Helen Taussig was a cardiologist. She had about 9-month-old baby. She's known with tetralogy, struggling, and she was admitted into hospital for about 40 days or so. The child wasn't eating or drinking anything at all. And at 15 months, she was weighing only 5 kilograms of weight. Around the same time, Alfred Blalock was the surgeon in Johns Hopkins at the same time. So she was asking him, can you do something about these blue babies? In those days, they're called blue babies. Vivian Thomas, you can see him. He's a great young man. He didn't go to medical school. He wanted to go to, but in those days, he was not allowed to go to medical school. But he was working as a lab technician with Alfred Blalock, working on dog models to do something with these blue babies. And in the lab, Vivian Thomas has devised what we now call as Blalock-Taussig operation. But because he couldn't perform, this operation was actually the original picture of the first operation ever performed. He's there somewhere standing behind. But he was the brain behind the BT shunt or Blalock-Taussig shunt. And that child survived. So the history has recognized his contribution a bit later. I don't know, the BT shunt should be called BTT shunts. There's some argument, Blalock-Taussig Thomas shunt, but certainly the Johns Hopkins has changed its name from Blalock-Taussig Pediatric Cardiac Center to Blalock-Taussig Thomas Pediatric and Congenital Cardiac Center. So 1950s, some groups have attempted with the hypothermia. So basically you cool the temperature down to 24, 20 degrees, and then go in and quickly do the operation. Walter Lillehei, he's one of those pioneering initial surgeons of attempting to do full repairs, intracardiac repairs. So what he has done is that he used an adult as the bypass machine, basically. So he connected the child to the adult so that the adult does the circulation, and he would go and operate on the child. And in 55, he's reported 32 such corrective procedures. But the program has to be stopped because one of the adults had a stroke and died, and it's become very unpopular, and the program stopped. But around the same time, around 1953 onwards, the heart-lung machine started being in clinical use. In 1953, John Gibbon performed the first surgery ever using a heart-lung bypass machine, and that is an atrial septal defect. So Gibbon worked with IBM to develop this machine. At the same time, Dodrill in, where is that in the north? He worked with GM Motors, where it's based. And they devised another pump. And these pumps, initially, you can see quite a lot. They used to occupy the half of the theater, the pump itself. But cardiac surgery has taken off since 1950s. Two things were important are three things. One is the heparin for using the heart-lung machine that was already been in practice or used. It was invented or discovered in 1915. In 1929, the cardiac catheterization, first cardiac catheterization was performed by a surgeon on himself. I'm sure you must know the story. So he's a bit of a crazy guy. He initially asked his colleague to inject or put in a catheter and then tried to put a catheter into him. And the next week, he wanted to do it himself. He took the help of a nurse. He went to theater. He put in a urinary catheter up his elbow. And the nurse was showing with a mirror, so he could advance and went to radiology and then did that. The hospital wasn't happy. They said that such methods were good for a circus, but not for a respected hospital. That was, he has written himself. But that has changed because the attempts of surgery before that was a more or less bit blind. It was only clinical diagnosis. There were no echocardiogram in those days. So you think of a diagnosis, you go and then find something different or associated lesions which you never encountered. So that's why the mortality was quite significantly high. So around the same time as luckily with the heart-lung bypass mission into clinical practice, echocardiography came into practice as well, which made it very easy. So it's always cardiology, cardiac surgery click together. There's nobody without the other person. So then the interest made, I mean, the initial operations were in older children because the mortality was so high around that time. In 1970s, two groups have published their experience of operating early. And one of the major ones is from New Zealand, Sir Baron Barrett Boyce. So he has demonstrated successful primary repairs in infants. At the same time, Boston group has also published their experience of early repairs. And in those days, people believed that early physiological correction is good for these growing children. And one of the examples quoted I put then here is the neonatal brain and the adult brain. So the brain matures early. People say that within the first year of life, you get a lot of growth and development within the brain. So put some of the weights here. Neonatal brain weighs 350 grams, 3 months, 500 grams, 6 months, 660 grams, by 1 year, 925 grams. And then rest of the life, you can grow only a little bit. But around the same time in 1970s, prostaglandin came into practical use. That made a huge difference. But up until then, they were only operating on children who survived 2 months. But prostaglandin, you could keep them alive for a few days at least so that they could go for surgery. So then we have seen a rapid growth in congenital and then neonatal cardiac surgery as well, 70s to 2000s. That's increased diagnostics were available from echo to 2D echo, angiogram, CT, MRI, 3D printing, 3D echo. Now we are gone into virtual reality imaging. Improved anesthetic techniques, where babies and infant babies were anesthetized safely, along with the improvement in heart-lung missions. And availability of equipment, microvascular instruments, and etc. And at the same time, a development of intensive care to look after the babies and children with dedicated PICU team. And that led to exponential growth in pediatric and the neonatal cardiac surgery. We put in one of the circuits here, see how small the tubing is, and then they cut in shorter and shorter so that you use shorter circuit for neonates. The previous problems were bigger tubes. Longer circuits means that quite a lot of volume to fill those things, what should replace a neonate body blood volume. Bypass techniques have improved, and then improved in surgical techniques and the temperature as well. In previous eras, people were cooling, and for most of the operations, cooling the temperature in the sense, in early days, it's hypothermia and hypothermic circulatory arrest for simple operations like VSD. So when some of the ACHD patients, when we see recently who had their VSDs closed 30, 40 years ago, we're surprised to see that those operations were done under hypothermic circulatory arrest. So a lot of things have improved, and we have new valves, patches, and etc. to deal with them. So take one of the examples, common, and see how it's evolved. Transposition of great arteries. Initially, as you know, the surgeons were doing only atrial switch operations, and Senning, A.K. Senning, was the first one to describe his Senning operation, He's from Sweden in 1957, but that operation wasn't reproducible. It's a bit complicated connecting the baffles using the patient's own tissue of right atrium and the septum. But Mustard in 1963, Mustard is from Toronto. He has devised a simple operation. He's taken the atrial septum out, so it's become one chamber. Then you use the artificial material to reroute, and thus become popular. So these two operations were popular until 1975, when Jatini is a Lebanese origin surgeon from Brazil. So people started doing coronary bypass grafting. So that grew confidence in the surgeons that we can do this in children too. So in 1975, first arterial switch operation was performed by Jatini. But these were children or infants. In 1983, the first neonatal arterial switch operation was performed by William Norwood and Aldo Castaneda in Boston Children's Hospital. Other procedures developed which changed are Fontan or single ventricular circulation for hypoplastic left heart syndrome. The Glenn shunt was devised quite a long time ago in 1958 by William Glenn in USA, but this was used for other conditions like tricuspid atresia. Then in 1968, Francis Fontan did first Fontan operation once again for tricuspid atresia. So for those group of patients, there is a palliative pathway of Fontan circulation from 70s onwards. But then a group of neonates which have no option are the hypoplastic left heart syndrome. And William Norwood, he has come with this idea of Norwood operation, and first Norwood successfully was performed in 1983. Then there's further increase in catheters, catheter-based procedures that has complemented and affected the neonatal cardiac surgery bit in terms of numbers. So previously, instead of BT shunts, we are now doing, we have much more options of either a PDA stent or a RVOT stent. PA bands, now you have an option of intraluminal occlusion as well. But one particular thing which complemented cardiac surgery is the hybrid Norwood. So particular group of children, low birth weight or contraindications for cardiopulmonary bypass, when you can't do a Norwood, then you have a hybrid procedure working with the interventional cardiologist. You can keep the PDA open with a stent. You can do bilateral PA bands and then do a balloon atrial septostomy. So basically, you're doing a Norwood operation with low risk in these patients. And simultaneous developments around the times. Initial classical Norwood included a BT shunt, but people observed that this can create a diastolic steal, hemodynamic instability postoperatively, until a Japanese surgeon, Sano, has devised RV to PA shunt, which people have improved that better outcomes. And then that has changed more or less into Norwood Sano in most centers. So what have we achieved so far? So more complex operations were done for wider variety of congenital heart disease. There's improved mortality and morbidity. And we developed a multidisciplinary approach, truly multidisciplinary approach to cater for these patients. In reality, for neonatal cases, especially, the dual operating has increased significantly. Two surgeons or two consultants are operating together than one surgeon. So in UK, about 12 to 15% of surgeries are performed with dual operating, and there are standards too. So this is some of the activity in the last 10 years, just a reflection of how the procedures are done. As you can see, the EP has significantly increasing, that's taken off. Cardiac surgery has not changed much, and if at all, it's decreased significantly during the COVID time, along with there's some increase in interventional numbers in UK. 30-day survival or mortality in children under 16 years. This is once again, a 10 years data in UK and Ireland, except Scotland. Scotland doesn't contribute to NICAR anymore. But you see the survival has improved from 2.5% to about 1.9%, but over the 10 years, the survival is excellent, 1.8% for all congenital operations. So we looked at what's happening. Anybody looked at overall to see how can we summarize the achievements we have made in congenital and neonatal. So this group from Norway has shown that there is marked sequential increase in operations for complex defects, which were not operated before, with the median age of first operation decreased from 1.6 years in 1975 to 0.19 year by 2011. And it also showed that the survival has improved. Previously, for first group of these patients, the survival was 62% up until 1990s, but from 1990 onwards, it's gone up to 86%. And later half in the 2000s, the survival has improved much more. The 1 year survival, 90% to 96% from up to 2011. And 5 year cumulative survival, 88% to 95%. So there's significant improvement in survival, and also they looked at freedom from reoperations, which has improved as well. So when you look at neonatal operations, the Japanese cardiothoracic registry shows that there's significantly increased operations being performed in neonates over the years from 1996 to 2010. You can see, especially in hypoplastic left heart syndrome, and the mortality especially is significantly improved. They had a neonatal mortality of 21% in earlier years, 1990s, to 6.9%. For this group, hypoplastic left heart syndrome, they had a mortality of 75% initially, but it's come down to 17%. And current mortality in Norwood is about 10 to 15%. So the hurdles, one of the main hurdle is the congenital cardiac surgeons. This is the specialty which is not many trainees are interested in. Not many trainees are interested in the congenital training program in this country. There are two programs, one between Birmingham and GOS, and another program between Aldehay and Newcastle. And in the last 6 to 7 years, there are only 2 people who took that post into training. The ones who come are the fellows who come from overseas who have interest in this. And several surgeons left UK because of the working conditions. And there is bit of musical chairs between the consultants. In the last 6 months, a surgeon moved from New Zealand to Australia, and a Bristol surgeon moved on a sabbatical to New Zealand. 2 surgeons from Australia, one moved to Dublin, one moved to Houston in America. A surgeon from London moved to America. A surgeon from Leeds went on a sabbatical to Middle East. So I don't know the reasons, but fundamental reason is it's the working conditions and the things which we see in the NHS, how the things are deteriorating. Currently, there's a big problem the country is facing. All units have some kind of a problem. Either it's surgeons or human resources or staffing of other areas. Frequently, it's the ICU or theater staffing, so that you don't have good operating here. And what can be improved? There's still further room to improve in heart-lung bypass machines. At the moment, they're good for up to 2.5 kilograms. So that's why we always quote that bypass is better, or the outcomes will be better when the baby grows up to 2.5 and above. But the ways we need to improve to operate under 2.5 kilograms safely. And for that, we probably need to work more on the CPB machines. Challenges, we see more and more premature babies these days. The neonatologists are excellent in keeping them alive. The survival is improved in premature low birth weight babies. And we see more and more babies with other congenital abnormalities. And we see genetic disorders we have not heard before, and the consequences of that. Now we have parental groups, well linked with social media. So they're well aware of the options they have. And that can sometimes may be different from one patient to another patient, but that can put pressure on the treating physicians and surgeons. Parental expectations are high. Nobody wants to give up whatever condition it is. And antenatal consultations, you might see and diagnose one thing and it might be different. So you cannot really see everything through antenatal scans, and the single ventricle pathways are especially challenging. Single ventricle pathway, though the journey starts antenatally, it's a long journey for the patient, not only the patient, for the family and the siblings. We have good single ventricles. We've just discussed today. We thought it's a good, but we have not so good single ventricles, and that makes the decision very complex. And we know from literature that hypoplastic left heart syndrome with aortic and mitral atresia, they have not so good prognosis when compared with you have a mitral and aortic valve stenosis. Restrictive interatrial communication still poses challenges for us. And then we have to think of interval mortality morbidity with the Fontan circulation, quality of life, etc. Fontan failure eventually leads to transplantation. In UK, about 200 Fontans are done each year. And the statistics show that already about 250 struggling Fontans identified, but the number of transplants in ACHD group happen in this country are less than 20 per year. So this is the burden which we are going to carry on for the family and for the society. But decision making at a neonatal age is very, very difficult. Neurodevelopmental and behavioral abnormalities, there aren't good studies looking into children after these procedures. But saying that we can't blame everything on a bypass machine or a congenital operation, this study, I think it is from King's College, it shows that they've done MRIs for all the babies. It shows that babies with congenital heart defects, even before any intervention, do have brain abnormalities. And one thing significantly they say is that TGA with septostomy has associated with more brain abnormalities than not. And as I said, the parental pressures. So this is a hypoplastic left heart syndrome. This is ascending aorta. As we see, it's the size of the coronary artery. So doing a DMS with this is really, really technically challenging. It's not only challenging, the anastomotic stenosis can trouble. We've attempted, we failed. Babies might have survived for a while and then died, but the pressure is still there because, as I said, that the parents do hear good stories from parental groups. They do not think that every individual case is different. For one particular case, the parent was a doctor, but we had to take 3 opinions, and universally everybody said that do not start, do not operate. So the next challenge in neonatal surgery is unbalanced and borderline left ventricles. These are unbalanced AVSTs and just borderline left ventricles. It's evolving techniques these days. The idea is that if you give an opportunity for the left side to grow, it can cope and it can grow, and then you can get a good biventricular repair rather than univentricular repair. And that is the idea. I put one of the example because it included everything. We are talking about the challenges: premature baby, low birth weight, unbalanced AVST with hypoplastic LV, hypoplastic arch. But the expectations was that we have to do something, and the parental expectations are to push for a biventricular repair. We took a second opinion. They said that maybe 50% risk, but we grew up to 2.7 kilograms. And this is echo and MRI. As you can see, that left ventricle is a right ventricle. Sometimes you can be misled because of the volume of the blood, but it was hypoplastic, or borderline, I would say, not hypoplastic. So initial attempts was hypoplastic arch repair with a PA band, loose PA band. 2 weeks later, tightened the band. 6 months later, PA debanding, AV valve repair, and fenestrated AST closure. And the left ventricle did grow, and the baby has survived, but needed reinterventions. Boston is doing important work in unbalanced AVST group. So their results are encouraging too. So they have done a biventricular conversion in about 67% of the patients, which otherwise would have gone to a single ventricular procedures. So in conclusion, the achievements are that we are performing increasingly complex operations and safely with excellent outcomes. The hurdles are resources mainly, and funding, and the challenges are increasingly premature, comorbid patients with low birth weight, and expectations are high, and biventricular conversion is the topic of or a big challenge as to how we can avoid univentricular operations in these children. Thank you.
Thank you very much. Thank you, Ram. Thank you very much. Does anyone have any questions? I've done quite I find the history of cardiac surgery very interesting, and I've read quite a few books on this. I was wondering, what do you think the future of congenital heart surgery holds? I know you've touched on it a little bit, but particularly, I feel like innovation in cardiac surgery has been limited because everyone's worried about safety and everyone's worried about, mortalities. So how does that affect in terms of innovation? And I think most of the previous surgeons who've been successful in device operations had, I think, the allowance, in inverted commas, to experiment and try and improve techniques and then come up with some really interesting kind of surgeries. So what do you think, in your opinion, is going to happen in the future?
The surgical innovations are limited for various reasons. But the interventional innovations have improved and increased. Yeah. And you take up any surgical procedure, there is an attempt to do it interventional. The bilateral PA band, it's not been around for last 5 years or 10 years, less than that, but there's an intervention as to how can we occlude bilateral lumina. So why is that we can innovate in device market, but why we can't innovate in surgical thing? And you quoted some of things, the risks and etc. And there's not much progress we can see as well. The only conditions which we can in neonatal surgery is to improve is the Boston, which is already doing to how to prevent or how to make a child or put a child into biventricular route rather than univentricular route. That's the only biggest challenge I can see in neonatal surgery. And the other biggest challenge is hypoplastic left heart, fully hypoplastic with bad comorbidities. Whether you can attempt to do a repair of the valve and do the normal at the same time, but technically it's challenging. Probably there's a scope. People start attempting and then they report success. That will inspire other people to do it. But as you said, there are limitations. The risks, it's not easy for surgeons to take those risks and then do it when you have this mortality counted every year in the US every year. That courage is gone, unfortunately, for surgical innovation.
Go on.
So a different set of questions, like in terms of the training you started off with attraction towards congenital surgeons as well as the adult cardiac surgeons. So in North America, there's a few papers on training is coming, like surgeons doing more. I mean, while you train as a surgeon, you simultaneously train yourself as an interventionist. So surgeons doing more intervention, being kind of having a backup by themselves, and the vascular anatomy by themselves is better than a cardiologist doing it. Is that for future generation? I'm just saying, is this on your views on this? Will that attract more trainees for surgeon, or is it a model that you support or you don't?
I don't think so. It will attract more. It may be a good idea to do because it happens in other areas, like the vascular surgeons. They do interventions too. They train in some of the European countries as well. The surgeons went and learned interventions and then did it together. But that doesn't necessarily attract trainees to come into the specialty.
So the surgeons in China, we should do both. Well described. I think it's a good idea. I think that the challenge that I see, which is similar to surgeons, is we have found very few trainees in the last few years who want to do intervention. And I think that particularly after COVID or around COVID, there's been a real change in what people want in terms of their life, because they suddenly realize that it might change the next 5, 10 years and people start forgetting about COVID. It doesn't become relevant to the new generation of trainees which come through. But I think a lot of people have realized that there's other things in life that they want to do than coming to work, and that has an impact in terms of how many hours you want to put in. So being interventionalist or a surgeon, you are spending so much time training to start off with and then finding work. And I think that's the question I was going to ask you is how do you change that? Because it's a problem in the UK. I think we've lost a lot of really good surgeons out of the country because now the pool is small, so the offers are huge. And similarly, a lot of interventionists have left. And how is that going to be? I don't know if there is a plan, or have you had any conversation in terms of how to reverse that, or what are they going to do in the future?
So it has to be an international effort, because the problem you see is that the volume is important. For you to grow as a surgeon, to operate in neonates and then operate confidently and good results, you need to operate quite a lot. And that is one of the problems in developing countries, that you don't have that much of volume. And the training also generally, as we see, is changing. When the generation before and the generation as we did quite a lot of adult surgery, a lot of adult operating before coming to pediatric. But that's not happening these days. And one of the problems is that we have surgeons, we don't have volume, but there are places there's a lot of volume, there are no surgeons. So when you can balance that, when you develop programs where people are allowed to or can go to where there is volume, like countries like India, Asia, China, a lot of volume, then you can gain experience. And one surgeon did actually. He went and spent some time in Bangalore to improve his volume. If you can incorporate that into program to say that you can take 1 year to go into these countries to operate. But still, I think the general interest is not there. Salim has already addressed some of the reasons why the hours, the stresses, the complexity and all those things. We had safe and sustainable review. I think you're all very young. You don't know about this. About 10, 12 years ago, we spent, we spent millions of pounds for that. And we're supposed to close some center that never happened because of pressure. But there are indications that it's coming back again, because all centers are struggling at the moment, surgically, what I mean. So there is another push towards another attempt to centralize, to close some units.
That makes it even more unattractive for us as colleagues, I think, because, for example, my husband, I drive him mad. He's like, did you have to pick something that was so niche that you can only do in a handful of places in the country? Because it really does affect your life, and not only yours, but the people immediately around you. If safe and sustainable goes back on the table and they close another 1 or 2 units in the north, again, you're expecting families to travel hours, be hours away from people that they need to do, difficult times in their lives, all that complexity. And then as a clinician, it's like, well, why would I do a specialty where I can really only live in this bit of North England? That I don't get it.
So I think that's a good. I think that argument is used when the safe and sustainable argument took place, or the discussion took place. That was the fundamental aspect, but I don't think that is actually quite relevant, if I'm completely honest, because people move in different parts of the country. I have moved from London to live here purely for not for the job, but because of the lifestyle change. But I think what is important to understand is when you look at other countries, for example, you look at Canada, there's 4 centers in the whole of Canada. One is in Toronto, one is in Calgary, one is in Edmonton, one is in Vancouver. I think there might be 3. I know, one in Montreal. So there are 4 centers in the whole country, and they travel. So I think from Toronto, the catchment area is actually almost a 3-hour flight. But they manage and they give a fantastic service to everyone. So the question is that are we, by having 11 centers, which we have in the UK, dilute the amount of cases that we have in a particular center. We dilute the expertise in some ways. We have already seen there's a difference in practice between, for example, London, where there's so much financial availability compared to the north, in terms of specialists and people and machinery and equipment and all that stuff.
I mean, if you tell me you can halve the number of centres, but make those remaining centres that much more well-resourced, I would buy into that, but I don't trust the infrastructure is not there. And so when they close these centres, if they close these centres, they will not then plough resources into the remainder. It will just be more flow will go in there and we'll cope. It won't be that the infrastructure is made sure that it's there. It won't be that it's supported appropriately so that it can grow. I think we'll just be in the same restrictions that we're in now, as in we all work a lot with one hand tied behind our back at the moment, I think.
But that's NHS.
And that's the thing.
Yeah, it's but yeah, I feel like I never thought about this before, but I think in the last couple of years, I feel like maybe there are too many centers in the UK.
The general push, the thinking is that maybe the north needs only one center between Alderhay, Leeds, and Newcastle. Midlands, one center,
Should we
and
start campaigning
one at
now?
London.
When they approached it the last time, they hadn't given a thought to how spread out some of the very niche services are. So when they came out with the public consultation, they went. And they said that Leicester was on the table to go. And I said, what are you going to do with the ECMO service? And they said, oh, a different whole different group of people was looking at the ECMO service for the company. I'm like, but you can't make a unilateral decision to take away the centre that is our only like flying ECMO service.
Yeah.
'Cause
Yeah,
what are you gonna do?
mobile ECMO.
They haven't made any provision for the ECMO, because that was a different team.
They spend a lot of money
So
having
it just
conversations as well, don't they?
Millions of
Spend an
pounds
awful
went
lot of
in,
taxpayer money
and eventually
consulting, and then it comes
on the
to-
center remained the same. But what came out is standards came out of that safe and sustainable. The renewed attempt now is just started of looking at it again, and this time because of the center struggling, all the centers, the guys, in Evelina and Brompton have already merged into one.
Yeah.
Yeah, thank you. Are there any questions?
I have the thing before they decide the entire of it and then it's one service. It's probably not. A bit smaller than the entire.
You need to think of the patients and the parents that travel, and the neonates being born, and how do you transport somebody from somewhere on the borders to wherever.
It's a big job, isn't it?
Anyway, thank you very much.
Thank you very much. Thank you guys for a 2-week break. And thank you
Enjoy
for the sponsorship again.
Enjoy your break.
Thank you, everyone.
Thank you.
Thanks, man.